Welcome everyone to George Mason University's celebration of Public Health Week from our new College of Public Health, the first in Virginia. My name is Dr. Susan Durham, and I'm on the alumni board at George Mason. I got my doctorate at George Mason. I have an undergraduate degree in nursing from Penn State, and a million years ago got my MPH from the University of Illinois. Back then, it was not really a highly looked upon thing in nursing to have an MPH, and actually had a difficult time getting a job in academia because my master's was in a different field. But we had a very futuristic dean, Rita Carty, back then, and she saw the value in that. And so she hired me. And so I did teach at Mason for a while and then Catholic University, both in public health. And anyway, I've worked in public health and also taught it. I would like to thank our panel for being with us today. They're all graduates of George Mason and have gotten a public health degree or are in the process of getting a public health degree. And I will let them introduce themselves and tell you a little about their careers as well. So if, let's see, who would like to start? Stephanie, would you like to start?
Sure. Hi, everybody. My name is Stephanie Funkhouser. I am a two-time alum from George Mason. I got my bachelor's in nursing in 2020, and just in December, I graduated with my master's of public health. My background as a public health nurse is in homeless health. I worked on a medical homeless nursing service and harm reduction program out in Arlington for a while, and now I work for George Mason as the Health and Wellbeing Coordinator under Student Health Services.
Great, thank you. Next, let's see, who do we have next? Shineca, is that how I say your name?
Yes. Hi, I'm Shineca Solomon. I'm a public health nurse with Arlington County in the School Health Division. I received my bachelor's of nursing from Marymount University. I also have a bachelor's in psychology from UNC Chapel Hill. And my background is mostly in pediatrics. I've been working as a public health nurse since 2020. So at the start of the pandemic is when I started in public health. And that was also the year I graduated from George Mason with my master's in public health.
Awesome. Thank you. And Kim, last but not least.
Hi, everybody. I'm Kim McNally, and I've been a registered nurse since 2015. I actually started my education journey with a degree in social work. So I moved from social work to nursing. And then I do not have a degree in public health yet. I'm in the process of getting a PhD in public health right now with George Mason. I have done both acute care and telemetry in the hospital. And I also, I'm a military spouse. So I've had the opportunity to move around to several different areas. I worked as a communicable disease nurse in North Carolina, where I managed their TB program. I worked in the STD clinic and also in immunizations. And then I had the opportunity to be a community health nurse on a Marine Corps base in Hawaii. If you haven't been, I would recommend it. It was lovely and beautiful. And now I am working towards my PhD. My concentration is in social and behavioral science. And my research interests revolve around HPV vaccination and the role of the school nurse in adolescent health promotion.
Very good. Thank you so much for being here. And I'd like to introduce Dr. Kathy Huddleston, and she's sort of the co-moderator. And Kathy, if you just tell us a little bit about you.
Yeah, I'll do the when you guys say 2018, 2020, 2015, I graduated in the mid 70s. And at that point in time, I was one of the children who often went to the dean's office for numerous issues. And so as we were talking nearing my graduation, I said, Dean, I'm really confused. I love public health and I love ICU, and they just seem like they're two ends of the continuum. And she very wisely just smiled at me and she said, no, they're the same nurse. She goes, you want to be an independent practitioner, you want to be in the throes of a bit of chaos and craziness. And I, think that probably fits. So I thought that was pretty astute. I had done a public health internship in Alaska, Fairbanks, Alaska in the mid-70s, and looked at that and said, yeah, I'm not sure that's exactly what I wanted to do. But I ended up going critical care, military spouse, so kind of went from coast to coast and overseas. And so I went from midwifery and public health to ICU and trauma. And then when I met Dr. Durham, I was in my PhD program at Mason in the early 2000s, and it was right after 9/11. And I realized that we really had absolutely no planning for pediatric disaster planning. If you looked at our national stockpile, it was all 18 years and up. We had no diapers, no formula, no pediatric doses of medication or anything like that. So that was my passion going in. So I was able to kind of blend my ICU background and my desire, sometimes in the back of my head, to pull that public health component out. So I did strategic planning and emergency responses and resources as my dissertation topic. Now I have come full circle again because I'm the principal investigator of a NIH study, basically the National Children's Study version 2 called ECHO here at Mason, Environmental Influences on Child Health Outcomes. So we're really focused on that public health core foundation of what is the environment doing to influence our child health and those projections into our adult health. So I find that the 5 nurses on truly have that nurse and public health and that sweet spot of how we kind of blend it all together. Thank you, Dr. Durham.
I would like each of the panelists to sort of think about what sort of caused you to consider a degree in public health and how it has influenced the way you look at your career now. And you can, Kim, you can just talk about sort of in the future how you think it will influence. So we can start in the same order if you like.
So I almost dropped out of nursing school after my junior year. And I was kind of having this like midlife crisis almost of like, oh my God, what am I doing? I came in here and nothing really seems to stick. And I did this internship about social justice in Richmond. And that's when it hit me that public health was really it. And I remember distinctly on my first day of my senior year, I went up to Tracy Davidson and I said, I don't think I'm going to take my NCLEX. Can you tell me like about the MPH degree? And she said, Stephanie, I will teach you everything you need to know about public health and I will help you get into a program, but you are taking that exam. And I'm really glad that she did. And she took me under her wing and I learned a lot. And really a big chunk of my decision to go into public health was the experiences that I had at the Mason and Partners Clinic. But also bedside nursing or hospital nursing was never really it for me. I knew that. And so I just like had this passion for public health nursing, I think, that I grasped onto and did not let go. So really getting the MPH wasn't, oh, maybe I'll do it later. I really, really wanted to do it. And so for me, it really like doing it impacted my career because it allowed me to make nursing what I wanted nursing to be and have a really different experience in nursing than a lot of my colleagues, I think. But I'm very happy that I went that route because if I hadn't, I don't think I would have enjoyed nursing the way that I do
Been
now.
happy, yeah. Shineca?
So my story is a little different. I started out pediatric hematology oncology, working in the hospital, which I absolutely loved until I had my daughter. And it was then after that, every child I saw as a new diagnosis, I thought of her. And so I had to remove myself from that for a while. I did outpatient after that, nephrology, infectious disease, and I kind of was starting to get bored. But I did not want to go back to the hospital to bedside nursing because although I enjoyed it, having a young child, those hours, it wouldn't have worked for me. So I went back to school. I was like, what do I want to do? And I've always wanted to keep going, get a master's, maybe a doctorate one day. And I don't know what called me to public health, but I was just like, let me try that and see how it goes. And I'm glad I did because it opened my eyes to what was out there, global health, environmental health. There were things that I just didn't think about because I was so patient-centered and patient-focused that I didn't really think about communities. And getting a master's in public health helped me to see how, it's very important to do preventative health and look at communities and the globe instead of just the person sitting in front of me. So I'm glad I did it. And I love it now, but I don't know why before it just I never thought of it, and no one ever said anything about public health to me. It was just, I happened upon it.
It's not even in boards. There's not a question because the AD nurses do not take public health nursing. And so they cannot offer boards and ask questions about public health.
Wow.
So that's kind of discouraging. And I can understand what you're saying.
I can't say that I took a class on it in nursing school either. Like, I don't remember anything being about communities or as much preventative care as except for like who the person sitting in front of you, not your whole community and cities and so.
Interesting.
Yeah.
I think for me, I do remember my community health course. I took it. I went from ADN and then to a BSN program. And so I do remember taking community health in my BSN program. And I did like an internship at the health department. And I was placed with the immunization nurse there. And I just really didn't think I was going to love it. I went in kind of like thinking, oh, this is just a check in the box. But they were just so wonderful there. They taught me everything I needed to know about immunizations. They had a travel clinic there, and I got to learn about what immunizations you need if you're traveling to another country. You need yellow fever to get in this country and this vaccine for this country. And then I was able to shadow the nurse who managed the TB program, and she also worked in the STI clinic. And I just really fell in love with it's almost like a mystery too when you're doing like disease surveillance. We also got the reports in, and you'll get a report from the hospital that says like positive for salmonella, and then you get to like kind of like launch into this investigation to try to figure out like, where did this come from? So you get to call a person and say, tell me everything you've eaten in the last 7 days. And it was new. Every day was new. Every day I was learning something new. I really, really enjoyed, which sounds crazy to say, but I really enjoyed working with the TB patients because the therapy is so long. You really get to know so much about them, so much about their families and their cultures. And so to me, the whole experience was really rewarding, but it was definitely that internship in the community health course in my BSN that I was like, wow, like this is so different and so much fun.
Thank you. Kathy, did you want to chime in? Or?
Yeah, it's just interesting to me, the old timer here. I think and Sue and I had some casual conversations about this, that a lot of times in my generation, my perception was you started out as the bedside nurse and you had that caring for the patient. And then, of course, I was pediatric, so we always bragged that we always cared for the family earlier than the rest of the world did. But, we cared for the family. But then you got to that point in your career that you thought, you know what? There's a community out there or a population out there that I need to be, I can take my skills up the next level. So graduate work seemed to be when you were really kind of enthralled and pushed into community, what I would consider community nursing, community, public health bridge. It's fascinating to me that you guys really did this. Shineca had a little bit different, but and I had people tell me the same thing. When you have a baby, you can't, you're not going to be able to go back into peds trauma. And maybe because I had boys, or I just don't have your part. I didn't have any problem at all. So I stayed at the bedside for a long time with that. But the transition from bedside to community, can you guys, and I know none of you are doing bedside now, but if you were to go back to bedside, could you talk to me about how you'd be either seeing things differently, or you'd be maybe happier, maybe, as Stephanie said, definitely not, something that, but that idea is there a bridge that we can go between public health and nursing? And should we have bi-directional traffic on that bridge?
So if I had a chance to go back into bedside nursing, I'd probably go into mental health. So when I originally decided that I wanted to be a nurse, that was the route that I wanted to go. And then I think I have a really unique experience having worked with the homeless population and kind of seeing this very broad spectrum level of impact that, the socio-ecological model has on people in looking at all of those different factors. And I think that if I had gone from public health into nursing, or if I were to go back into it, like going into a mental health place with the knowledge of like, I have seen the end result and have heard the beginning stories to it, it gives you a different perspective on the people that you're interacting with and speaking to, and recognizing that like there are so many factors that are out of our control that lead to things like this. And I think it almost creates a level of empathy that that maybe wouldn't be there if I didn't have such a detailed knowledge of it. But also, like, when you take into account all of the different theories of behavior change and stuff like that, pulling that into practice with clients one-on-one is something that I think I would do if I were to move back into bedside.
Anyone else?
I think if I were to go back, I would probably go back as like an infection preventionist. It will be very hard for me to go back as the one-on-one bedside nurse. If I had to, I'd do it, but it's just not my cup of tea anymore. But I did think about doing infection prevention in the hospital before becoming a school nurse. So that I could see doing that only because it kind of ties more in the epidemiology, those types of things with it. And you're looking more at the hospital community versus, the individual patient. I know you're looking at them too, but I think it would be really hard for me to go back. And if I did, I don't know what that would look like to be a bedside nurse for me. It's difficult for me to
Understand.
Yeah.
So you kind of feel like that caring for the population, you've kind of moved up to that level. It would be hard to go back to caring on that one-to-one basis.
I think so. I mean, I think because I'd be too busy trying to go beyond just getting them out of the hospital, that I probably wouldn't be as effective. I'm so used to connecting people with resources and talking to them about, bettering their health and preventing certain things that I think, is it would be hard. I would be the one keeping people in the hospital instead of getting them discharged where they're supposed to be.
Yeah, I think it sounds like case management, right? Like
Yeah.
it's like when you're doing your discharge teaching and you're telling your patient, you know, these are the foods we need you to eat. These are the medications you need to take. Like the community health background in that, you know, undergraduate education is really crucial to kind of thinking through like, hey, do you have a place? Do you have a pharmacy? How are you going to get to the pharmacy to get your medications? You know, maybe we can, if your hospital allows, like pull them from the in-house pharmacy and give you at least the 3 days, you know, if you need to get a ride, or what kind of access to food do you have? Like, I think it just makes us better advocates for our patients. Like if we were to return to the bedside, I think each one of us is capable of doing it, whether it's our cup of tea or not, we could do it, and we would probably be pretty
Better.
effective. If not aggravating to maybe some of our coworkers by saying like, wait a minute, hey, like they can't go yet. They don't have the medications they need, you know, but I think it just strengthens you really all around as a good nurse.
Well, when I was preparing for this and thinking about some of the issues, I got on the APHA website. They have a sort of breakdown of some of the things they're thinking about daily for the Public Health Week. And some of the global issues that they mention are climate change, racial equity, accessibility, burnout of the public health workforce, and racism. And I was wondering if any of you would like to speak to any of those concerns, and do they in any way relate to, can you see them relating to your careers and your jobs that you're doing right now?
Can you repeat those topics real quick?
Sure. Climate change, equity, accessibility to healthcare, burnout of the public health workforce, and racism, and sort of how they relate to health and the vulnerable populations and things like that, that people that we're going to be, that we end up seeing when we're working in public health careers.
I think equity is a really big one. Coming from, you know, homeless health, like when we look at the population that we had, which was primarily African-American men aged 40 to 60 with severe mental illness diagnosis, like schizoaffective, bipolar disorder, and all of that kind of stuff. And then you learn about their backgrounds and where they grew up, and there wasn't that equity to them. They did not have what they needed, and that really impacts like everything that went on in their life that influenced the development of the diagnosis and things like that. And I think when you look at equity as a whole, as a like public health nurse or public health practitioner, like equity could fix a lot of problems in public health. And so for me, I think that I try and ask myself, for like every person that I'm interacting with, like, is what I'm suggesting right now equitable to them? Or am I just giving this to them because that's what I would give to just any client? And I think that's kind of where that influence leads to.
Yeah. Anyone else?
I definitely agree with
Okay.
Stephanie. Oh, sorry, I was going to say, in just the research that I'm doing, I'm doing HPV vaccination rates, but in the background research, I'm finding that there are definitely certain populations that are seeing higher levels of HPV related cancers, and yet that doesn't reflect the vaccine rate. So it's kind of opposite, like the population that is getting most of the vaccines is still having higher rates of HPV related cancers. And to me, that suggests that there is definitely inequities in access to screening. And so that's definitely where I'm seeing it. Like this is not a population that's vaccine hesitant. This is a population that either isn't getting equitable healthcare, meaning that they're coming in complaining of like symptoms and they're being dismissed by their practitioner, or they aren't even able to get into the to the practitioner for the screening. So I think it's definitely an area for sure that public health nurses are like, we need to be like looking at it constantly.
Absolutely. Well, when I was teaching public health at Catholic University, I used to show my students this, it was a video and it was in segments. It was actually over a period of days, and it was related, it was called Unnatural Causes, and it was related to health and wealth. And we asked them to look at, you know, some of the research done, and then on how wealthy a person is. They sort of looked at a spectrum of people from like the lowest income level to the highest income level. And for example, somebody who gets small cell lung cancer, who's in the higher income level, will live longer than the person in the lowest income level. And so, you know, it was really hard, I think, for a lot of my students to sort of grasp that and understand how, and there wasn't any one thing that sort of stood out as the reason for them living longer, other than, you know, just better nutrition throughout the lifespan and, you know, things like that. And so it was something that, you know, gave us a lot of food for thought. Kathy, you have anything to add on any of those?
Did you have any comment, Shineca?
Yes, I was gonna say, I totally
I'm
agree
sorry.
with everything that's been said. One of our coalitions that I just joined, that's new to Arlington County, is looking at food insecurity and equity and how those relate. And even though Arlington's food insecurity rates are low in comparison to the state, you know, they still have issues with certain zip codes, and you know, just trying to figure out how to make that more equitable, make it where, you know, there's a grocery store within walking distance of houses, and, you know, food pantries, resources just for those people, and why, you know, it's easier for, say, the zip code right next to it to get, you know, access to these resources, whereas the, you know, people living next door can't. So it's just that's one of the things that we're trying to work very hard to improve in Arlington County.
Also, the fresh fruits and vegetables not available in like the small little grocery stores
Right.
that are
Dollar
available
store.
in the corner. Yeah,
Yeah.
things like
You
that.
know, Shineca mentioned the magic word to me as a genomic researcher that I was. You know, the joke is always, you know, your zip code's going to predict your lifespan a whole lot more than your genomic code.
Yes.
And so to look at that, I think that was APHA's motto. I have a t-shirt, and it was maybe 2016, 2017. And I thought that was a good, you know, and matter of fact, I think it was that conference that, and I'm blocking on her name, but it was the wonderful pediatrician who became a researcher out of, not out of choice, but out of necessity in Flint, Michigan, with the water.
Yes, the water.
Yeah, and it was a wonderful tale, and yet, and I know I'm my researcher hat is showing, but how do you guys see you've taken your nursing practice, be it no matter how short it was for Stephanie, and taken it from a person to a population or a person to a community. Now I want you guys to sort of go the next step. And how do you add research? Kim kind of talked about that a little bit in that questioning that vaccine hesitancy versus access. But where do you guys see as Sue was talking about burnout and accessibility, and I think the average age of the public health workers in their 50s. How do you guys see upping your game and upping, for our college too, right? As the first college of public health in the state of Virginia, what's our foundation? What's our platform? How do we drive research within public health as nurses? And I'm going to go back to you, Stephanie, and let you go first. I saw your eyebrows kind of going there.
I don't have an answer. My eyebrows were going because I was thinking.
Okay, fair
But
enough.
you've got such a wonderful group and your homeless group, even just to look at.
I think there was a time when I really looked at, like, I really was interested in like there's no research on it. You see it, but there's no research on it. Severe mental illness diagnoses in African-American men experiencing homelessness and like the background on it. Like there's no consolidated research about where they grew up. So you can listen to all the stories and say, oh, like there's the environmental factors. There's no evidence for it. And there was a point in time when I like was deep searching for evidence and could not find anything. So if I was gonna like step up that game, that was probably.
That's what you'd use.
There's your dissertation, hon.
Yeah.
Yeah, and I think that's so true. I mean, the environmental influences on child health. I ask if you've got any opportunity to look at ECHO, some of the research that we've come up with in the last 5 years, and that got an appropriation for the next 7 years. Hopefully, Mason will be part of that. It is such a you're really your center, Stephanie, is what they call DOHAD, Developmental Origins of Health and Disease. And you look at your, whether it's the placenta, whether it's the intrauterine environment, whether it's early developmental, early childhood factors. There's
Stress.
an awful lot of the Barker's theory pretty much says by the time you're 2, you're cooked. We can pretty much tell you what the rest of your adult life is going to be like, other than maybe you're going to become a motorcycle racer or something on that high risk gene that could be looked at. But your question is so solid, as well as what if you could give those homeless people, if you could wiggle your nose and give them a secure home, how would that change their physical health? That factor of being homeless. But I think, well, I guess what I was getting at was I want you guys to realize you all three have such a unique perspective on nursing research / public health research. I know the dean would be smacking me right now saying, no, it's public health research. But, that bridge again, that we go back and forth on, to be able to pull your nursing colleagues on that public health research journey with you. Shineca, you've got some, interesting observations from that real intense, pediatric oncology, which is so research heavy, which is probably one of the reasons why our research, our peds onc has got such high, success rates, is because we are research oriented. How do you see that experience kind of playing out in your public health world?
I don't know. That's it's interesting to think about it in that way. But I was going to say that we kind of already do the research as we're going. I was just giving a presentation on food insecurity in children to my colleagues. And a lot of the research I found was showing how children who are food insecure are more likely to be diagnosed with ADHD and have trouble in school when they're older, based on if they're in food insecure at younger ages. Once they hit school, they're the ones who are more likely to be diagnosed with a mental condition or hyperactivity. So I think I don't think it's like the research isn't being done, because I feel like we're always researching. Anything we do, we're always looking for the connection, and we're always, checking to see if someone has done any type of research on this thing. Just like Stephanie was saying, she searched, has anyone done any research on Black men and homelessness, and how they got there? So I don't think it's like two separate things. I feel like it's something we're always doing. It may not be concise and written in a paper form, but we
Gold
do it
standard
every day.
type of thing.
Right. We do it every day when we're trying to help our communities and figure out ways, just like with equity, like how can we make things more equitable? So we always research to figure out, well, why isn't it equitable in the first place, and what will make it more equitable? So I don't know. I just don't see it as two separate things. I feel like it's always intertwined. Like we're always doing that research.
Nice.
Thanks.
Kim, you were the one that you planted that seed with me. What's your thoughts?
Very good question, because I actually, being in a public health PhD program, I often questioned, was it the right way to go, or should I have done a PhD in nursing? Because I have, my master's is in nursing, I have a BSN in nursing, and I thought, which way do I want to go? And I think that's one of the wonderful things about having a nursing degree is you're versatile, like you can do so many things. So the way that I try to bridge those two is, and of course, in order to graduate, I have to bridge them, right? So I did that by first taking a research question that I was interested in, and then trying to recenter that around the nurse. Like how is the nurse involved in this particular, role of promoting HPV vaccine, of administering HPV vaccine? And the reason that I got to that point and was able to come up with that kind of research topic is because I was doing, like everybody says, you're looking for this research. I think we're so ingrained with evidence-based practice. Before we do anything, we want to see what has been done, what works, what doesn't. And I found some different research articles on how well Australia is doing in their HPV vaccine rates, so much so that they think that in the next 10 years, they can get rid of cervical cancer as a public health problem. And why is that? School-based nurses. So I'm like, oh my gosh, we could do that. If we really take a good look at our school nurses and promoting on-time HPV vaccination, we can do that too. And so I just tried to pull that back and really focus on the school nurse and say how valuable this person is, just in a lifetime of health. I know you had talked about, and I think it came up before too, how important that life approach is, that life systems approach, starting early. Where are our kids every day? They're in the community, they're in their schools. So I think it's just so important to really focus on how important community nurses are.
Well, I can't let today on the panel go by without mentioning the past 3 years and sort of the politics involved in the pandemic. And I just would like to hear your opinion on how do we restore trust in the government and the CDC and just in healthcare in general, and how has that affected your jobs in any way, and how do you see us moving forward? Stephanie, you have any thoughts on that?
I think that the pandemic really polarized people's opinions on public health, and that is really a detriment to the efforts that everyone in the field of public health have been doing. I think one, and this sounds like a very simple and easy answer, you just have to make people believe. You have to put in the work and show the outcome. And fight misinformation and educate people properly. And I think going back to that equity question,
Yes.
when we are looking at populations with low income, low socioeconomic status, low education from parents and all of that, you're going to come in contact with people who have incorrect knowledge, right? And so that is a direct product of not having accurate and not having enough education and health services and access to that. Like, that is an equity problem. You didn't get all of this information that you need to take care of yourself, and like that influences the way that we see, you know, that health belief model, the way we see the severity of a disease, our susceptibility to it, the benefits of changing. Can we even change, right? And so really, when we put into those populations that are not receiving equitable health care, and we educate and we really build the relationship and say, like, we're here to help on your terms, I think that is one way that we get to that, to getting people to, you know, believe in us
Yes.
again, because
I
it's not always
think, right.
politics. Sometimes it's just a knowledge deficit.
And also the Twitter, fighting the Twitter feed and the fake news and things like that. I mean, you know, so I think you're right to a certain extent, but no matter how much you fight to get the proper information out there, it is still going to be difficult with some, you know, segments of the population. Any thoughts, Shineca?
Yeah, so I think part of the problem now with trying to gain public trust is that most public health workers are burnt out from the pandemic. Like, I definitely was at a point, it's just you don't have the energy to put into it anymore. So it's more of a focus on what can I change? What can I do that's you know, the small wins, what can I
realistic
do?
goals? Yeah.
Right. Instead of trying to change someone's mind. And I think it also takes our mindset being a little different. Like, yes, we want to educate our communities, but sometimes it's more of, well, let me just listen to what they think and what they have to say, and then finding ways to navigate what they're telling you and insert just little things and go gradually, little by little, because you're at this point, some people are so far from even having an open mind to hear a small thing. So they have to feel like you're hearing them and you understand them and you might be on their side a little bit before you can try to, you know,
Yeah.
change their minds about things. So, and I think that takes a lot of work, and that's where it's going to take time, because a lot of public health workers are just tired and just want to, you know, work on something different because we've been so COVID pandemic focused for so long. It's like now a lot of people are like, okay, we're going to work on vaccines. We're just going to work on vaccines and, you know, making sure everybody starts getting their vaccines again, because you kind of have to change your focus sometimes just to give yourself a break.
Any thoughts, Kim?
I like what Shineca said. It sounded a lot like something that I was looking into. It's a technique called motivational interviewing. I don't know if anybody's ever used that before, but it's like learning how to talk to people in a way that you're not telling them what they should do and they're telling you all the reasons they're not going to do it or they don't want to do it. It's like trying to not engage in that like discord, to learn how to talk to people in a way that, like Shineca was saying, you're acknowledging why they're telling you they're afraid of the vaccine, you know, side effects, or what are your concerns. And one of the techniques of using the motivational interviewing is this ruler, like on a scale of 1 to 10, tell me, you know, how likely are you to get this vaccine? And if they tell you they're a 1, they're not going to get this vaccine, then you can say like, okay, well, you know, we can talk about it at the next time we meet or something like that. Or if they tell you they're a 5, you've got a little bit. So it's kind of like gauging where they are, why they're feeling that way, and not just as much as it hurts. So like, you just want to disengage, right? Sometimes, because it is like very, a lot of mental investment, but I think like we have to keep going.
Exactly.
And yeah, so I definitely, I think what Shineca and Stephanie were saying is like spot on.
Well, Kathy and I were both on the immunization team at George Mason, and I found, I don't know about you, Kathy, but even a lot of people that came in to get their shots and, had been talked into it or wanted to do it, they were still frightened. Some men told me they had never gotten a shot on purpose before, and we would have them, I would have them look at a doorway and focus on, counting the number of people coming in. And so then I would give the shot while they were talking. There was so many barriers out there. It was, I never thought I'd live through a nursing experience like that. I don't know about you, Kathy, but I mean, I've been in nursing a long time, but it was just amazing.
It was more
and
like my third world
challenging.
medicine
Yes.
journeys.
Exactly.
Well, and that kind of leads, we do have one question from the audience, and that feeds right on to Sue's comment there about, vaccinations right now. Anyway, it's, we had some experience within the pandemic of extending that to pharmacies and physical therapists and dentists and everybody. But really, when you think about who gives the vast majority of vaccinations in the country, it's your nurse. And so one of the questions from the audience was, how does your nursing degree help you to become better public health workers? And it was funny, I think we kind of answered that the other way around, but
Yeah.
your audience is saying now, is there a way that you can kind of pull in your nursing degree to say that gave you a better access or a better insight? Do you think having that anatomy and physiology, do you think having the social sciences, do you think taking the NCLEX, is there anything in the nursing brought to the table that made you a better public health worker? And I'll go in reverse this time. We'll start with Kim. I saw your eyebrows going again, Stephanie.
For me, I think that's an super easy question to answer. So I manage the TB program, and the pathophysiology of tuberculosis is just immense. And then when you're looking at things like antimicrobial resistance, like as dreadful as pharmacology is in nursing, like it was so helpful for me to understand. And it was very helpful for me to teach my patients, like, we're giving you these medications, but we're still needing to do like this blood work. And this is why we need to do this blood work. And it just really gave me the self-efficacy to help and treat those patients.
I have not met Kim, but I figured when I saw that question, I thought she's
Yeah.
the perfect, person to kind of go through that. Yeah. Stephanie, want to chime in?
Yeah, so like you said, Kathy, my nursing, like public health nurse experience is very short, boiled down to like a year and a half. But I think it really, like, to what Kim was saying about like the self-efficacy, I think when working with people to like try and make changes, like, and the motivational interviewing, like pulling those two together, I think is kind of how it works for me. But also in a weird way, nursing diagnoses, which I never used in nursing. But like when I sit there and I'm looking at things that are going on, like my brain is like, knowledge deficit. They said this because they were taught this their whole lives. So I think that that's like a way that I kind of build a lot of the programs I work on, and like build a lot of the information that I provide based on, oddly enough, nursing diagnoses. So.
Interesting.
I know a lot of people that would love to hear that.
That's right.
That I used to work for.
Shineca?
Well, totally agree with both Kim and Stephanie, especially, you know, just knowing the pathophysiology behind certain things. But I also think nurses, most people who ever go to a doctor, hospital, anything, they always see a nurse, right? So they look at us as the knowledge keepers a lot of times, like we're the ones that's gonna tell them how to dress their bandage when they get home, or when they can shower after a procedure, those types of things. So we already have that respect as a nurse just by having the title. So when I feel like when I'm trying to teach anybody, regardless of who it is, whether it be a family member, a student at the schools I work with, a parent, they always come to me because I'm the nurse, you know, just knowing what the nurse is gonna know. She's gonna, even when it's stuff that I don't know, that's
All
way
your
beyond what I
neighbors
should
too,
know.
right?
Right, but they're always gonna call on us because they know, they respect us as a profession, because in the past, that's who's always giving them the information they needed to be able to, you know, get better or do what they needed to do when they got home. So I think just having that title gives us a lot of, I don't know what word I'm looking for, but it helps us to relay the information to the people that need it. Like those people look at us as, yes, I can trust what you're saying because you're a nurse, versus, well, that's just John, my friend. He doesn't know what he's talking about, but the nurse will know. So I think that in itself has been a huge help in public health, just trying to educate anybody, because they're like, oh, yeah, you're the nurse, you know, you should know. Yeah.
Well, you know, and we were laughing. I obviously have friends and compadres
Yeah.
in the GCH department, and I'd say probably half of ECHO is not nurse, you know, it's not nurse or medicine. It's PhDs, but psych and social and clinical neurology and biology and anthropology. And I think what's
Epidemiology.
interesting is that collaboration.
Mhm.
And if there's not, if there's one word that I would, you know, with my gray hair, you know, hand out to you guys, is collaborate, you know. And the nice part, like you were just saying, Shineca, is you can reach out to that person. And there's something about being a nurse. The older I get, you know, you kind of walk around, you're meeting other people, and you can almost smell each other out in crowds. You've shared a very intimate moment with the human body, whether it was, you know, dropping a line or bathing or the death or the birth. There's very intimate moments that we have been privileged to share. And sometimes I feel that almost we wear that as part of that trust, part of that acceptance. And so maybe that's that piece of it. I surely need my epi buddies, and I surely need my, you know, clinicians, and I need my mental health, and I need my community resources and access, and I need all of those, you know, components. But I think your nursing hat carries a lot of weight when you're, you know, starting this process.
Well, I was thinking we should end on a positive note, and I was wondering if any of you can think of areas of excellence in public health that you've noticed either on the state level or county level, or just, you know, in your jobs that you can, that sort of gives us hope as we go forth, you know, on to the next year and the next challenge that's looming over us. And I thought maybe you would mention one of those. Could we start with you, Stephanie?
So just to make sure I understand the question, like what in public health is giving us a
or anything that you feel hopeful about in your job and, you know, in going forward, that's sort of related to the public health and, you know, the things that you're doing or the things that you're seeing coming down the pike.
Yeah, so something I mentioned earlier is that I really loved my experience at the Mason and Partners Clinic. My senior year, before all the craziness happened, there was a group of students and we were getting together to celebrate 2020, the year of the nurse, Florence Nightingale's 200th birthday. It was all about advancing nursing, right? You
Right.
expand scopes of practice, you decrease healthcare costs, you make care more accessible to people who need it. And so I'd say really like that is that light that there is this vision of nursing going to this direction of public health nursing. And I don't work as a public health nurse anymore. And there's a part of me that wishes that like, not wishes, but there's a part of me that when that happens, I'm going to be like, man, maybe I should have kept up with it. But I think just this idea that you can merge these two to make to help change and make a better healthcare system is kind of that like light at the end of the tunnel. That's what gives me hope for public health. And Mason and Partners is a really good example of that, and just seeing that expand and keep going.
Very good. Thank you so much, Shineca.
I mean, we survived a pandemic.
Exactly.
People got vaccinated. Like that alone gives me, because there was a point where I was like, oh my goodness, I think we all thought that, like, what is going on? What's gonna happen? But we're on the other side of it, vaccines, just the time it took to create a COVID vaccine, that in itself was amazing. And
Yeah.
it worked. It's an effective vaccine. So, and just like for small wins, like as a school nurse, seeing that my families are actually getting their kids vaccinated now, even though, I have some I have to call constantly, but they go and they want to go and want to get it done, because so many couldn't during the pandemic. And now they're like, no, we want to get all of our, vaccines.
Yeah.
What else do we need? So
That's very good. Yeah, that is very helpful.
we got through all of that and we're here. So
Absolutely. Kim.
Well, I'm very excited that I got to meet, all these are pretty much new faces to me. Shineca, I would love to connect with you after the meeting, because my dissertation topic is school nurses and related to vaccines. So I would love to kind of see what your thoughts are in that. But one piece of hope that I have is Virginia particularly just had, and Shineca probably knows this as well, the gender neutral HPV vaccine mandate came out. So now we have a little bit better gender equity when it comes to that vaccine in Virginia. And I am really hopeful that Virginia can serve as a model to other states to show like really what an HPV mandate can do to cervical cancer rates in Virginia. And it will hopefully set an example for other states to expand that as well.
Very good.
And there was one question that came in that said, how can we help more nursing students see their role in public health? And to be honest, I think the answer that you three just gave that. The MAP clinics, the idea that pat yourself on the back, we survived, we not only vaccinated, but now we're pushing the vaccine through, and the idea of collaboration. And thanks, Kim, for saying you're going to hook up with Shineca, because I think if we collaborate between nurses and public health, we celebrate our successes. And yeah, I'm with you. Ladies and gentlemen, COVID was a success in the respect that it was not a miracle that that vaccine was created, because it was 10 years in the making, but we did it and we got it into arms. And it was nurses and public health together doing that.
And doctors and pharmacists and just multidisciplinary, it really was.
Collegiality.
Yes.
So
thank you so much, panel.
Thank you, Dr. Durham.
It was so nice meeting all of you, and your answers were spot on. And really, thank you so much for dedicating the time to do this and speak with us. We really, really appreciate it. And you really added to the celebration that we're having this week at GMU on public health. And I can't wait to see you around campus sometime.
Thank
And
you
please
all.
stay in touch with us.
Go Patriots.
Yes.
Thank you so much for having me.
Thank
You're
you for having me.
Thank you.
Thank